Yeah.
Is it all right if we start a little bit later than the beginning of the block? Just because we just found out recently about the extension, so there are a few more like notes I want to type up real fast.
Yeah, that's totally fine.
All right, cool.
Yeah, we can give more time for people to come in too.
Mm-hmm.
How's the virtual conference been going? And been a success today?
Mm-hmm. Yeah, it's been going really well so
Awesome.
far.
Before Brandon starts, I just wanted to introduce us. We're from DePaul University. I'm Alex, and our presenters today will be me, Brandon, Corbin, Imani, Zoe, and Noah, excuse me.
All right. Welcome. I'm Brandon. Welcome to our roundtable. The topic of today's discussion is going to be multidisciplinary research's benefits for regarding community interventions. Community psychology is kind of mission statement is using science to affect social change. So we're going to talk about using as like, approaching science from as many different fields as possible and how it'll consequently improve our data and then the interventions we develop based off of those, off of that data. So our roundtable is going to have two sections, and there will be a little mini discussion after each one. So the first section is going to be just some description of different fields, essays, where we have, for people unfamiliar with that specific field, just having that quick kind of throwing stuff out there. And then it'll also, be a primer for the part of the discussion where audience members will contribute, methodologies that, are specific to them that they think, are worth mentioning in this context. Well, we're going to talk about like biomedical assays, like neuroimaging and stuff. Demography, so how we understand these populations, because we have to know how to, describe a population before we can, design proper methodologies for them. And then the third part is going to be just more traditional essays, the self-report scales, the stuff we're already used to as community psychologists. And then we'll open it up for everyone to kind of throw in some more whatever they think is relevant. So the second part is going to be taking all the stuff from the first part and giving specific examples of how this has been implemented, in a specific context, and then the benefits that have occurred as a result of that implementation. So for example, like telling a story about a research project where you brought on someone from a completely different field and how that's benefited your team or whatever project you were working on. And then, also ways that we can address or ways that we can use this to make community level interventions, because that's the ultimate goal is to affecting change at this community level. So we'll start it off with biomed essays with Zoe.
Hi. So, as many of you know, depression is currently the leading cause of disease burden in the adolescent population. And right now, it's just really crucial for the psychology community to really begin to integrate, different areas within psychology in order to really expand these different approaches at eventually curing and improving treatment. So right now we're at a major cusp, specifically in regards with neuroimaging as a diagnostic tool. So time and time again, aberrancies in the reward system pathways have really, been linked to depression. And specifically, researchers from Brazil use this longitudinal design in a community-based sample to basically test the hypothesis that the reward system connectivity in early adolescence predicts depression 3 years later on at follow-up. So few studies have really looked at functional connectivity within, a reward system. So this approach basically quantifies the degree to which a specific node would then integrate signals with other nodes in a distinct system. And then specifically, the researchers wanted to look at the reward system in general, which included the ventral tegmental area, anterior cingulate cortex, and the ventral medial prefrontal cortex. So this study too was part of an ongoing study, and it included 57 schools from 2 Brazilian cities, Sao Paulo and Porto Alegre. So the first group was a randomly selected group including children between the ages of 6 to 12, and then the other was the high risk group, who had different types of psychopathology types of risks and stuff. So it ended up including, the final group ended up including 637 children. And so the methods of this study basically included an initial baseline evaluation with self-report only from the parents. So that was, and then an MRI was taken after. And then, so 3 years later, after this was completed, parents were recontacted in order to get a follow-up. And then they ended up doing another interview with the parent based on different psychological outcomes, specifically using the developmental and well-being assessment. And then also a certified psychologist then came in and actually interviewed the adolescent. So that was 2 different initial types of interviews that were occurring. And that was actually because data actually suggests that any type of self-report about depressive symptoms from oneself under the age of 11 is not considered accurate data, which is just extraordinarily important, especially when dealing with adolescents and things like that. So so that's why at baseline, it was just, the parents report rather than having the child report their depressive symptoms. And then, following 3 years later, they would be at that age of 12 and be considered adolescents. And then at that point, they were able to, report what types of symptoms they were having. So then in this study specifically, the researchers were quantifying depression based on merging the developmental and well-being assessment and clinical diagnosis of MDD through the DSM-5, which was very, very interesting. And then in order to determine the reward network, which I touched base on before, they basically ran through 1 billion different types of statistical analyses and then ended up coming up with 43 edges and then 11 distinct nodes, which was really, really fascinating. And again, there wasn't like in the article itself, there really wasn't any specific reason why they chose this distinct reward network other than the statistical significance between, you know, all these different areas of integration and then resulting in those 11 different nodes. So then they use logistical regression to then test ventral striatum node strength as a predictor of depressive disorder. And then again, using that DSM-5 clinical rating. So the results did confirm their hypothesis that the left ventral striatum node strength predicted depressive disorder 3 years later by 50%, which is absolutely like astronomical. So this basically what the study was able to do was that they're able to completely predict depression prior to the onset of symptoms. And then, you know, 3 years later, these children were having depressive symptoms. So this just like really opens up so many different doors for children all over the world, and specifically in urban city adolescents, you know, because it is just a very distinct population who tend to go and experience, you know, higher levels of chronic stressors. And then, you know, being able to combine like a type of treatment in order to then prevent depression maybe one day on. But yeah, so that's kind of what I have. So
going off of what Zoe said, she said that we're looking at mainly adolescents. And to give you more demographic information, adolescents in areas that are of low socioeconomic status, since people or children in those areas have a greater risk of adversity and stress that they can encounter in their daily lives. A study conducted by researchers in 2010 looked at primary and secondary exposure to community violence, and 3/4 of the children interviewed reported being victims of or reported witnessing community violence in their neighborhood. And out of those children, most of the parents reported that their children felt at constant risk while they were going about their business in their neighborhood. Another study in 2011 looked at community violence in relation to academics and how intervention could turn the effects of that violence in the community has on academic performance. And they looked at children who had reported witnessing or being a victim of gun or knife violence in their community, and they deployed 2 intervention techniques. One was one-on-one group counseling and one was group counseling. And they deployed these in either the first or second semester for different groups of children. And they found that in the first semester, children who received the intervention had higher grades in subjects such as math and reading compared to those who had received intervention in the second semester, since these children had just started up the process of school and homework, and they found that intervention helped cool off the effects that community violence could have on their academic performance. A common theme across both these studies was that in the first one, 1/4 of the families in those neighborhoods had lived in neighborhoods with poverty rates over 20%. And in the second, almost half of the students reported a household income of less than $15,000. Just to give an example, in Chicago alone, 7 neighborhoods have population, or in 7 neighborhoods, around 40% of the population live below the poverty line. And 4 out of those 7 have reported 700 violent crime incidents in the last year. In a statistical study done by the Bureau of Justice Statistics from 2006 to 2010, they found that 3 out of 10 violent crimes were unreported due to fear of retaliation by the perpetrator or getting that person in trouble. And they found that in another study, they found that 75% of violent victimizations, like assault in school, went unreported to the police. They were either dealt with by school officials, or a majority of them were seen as private matters, and they weren't talked about with any authority figure at the school. That's just to give you an idea of some of the adversities that children in these communities can face. And now we'll move to Noah with measurements.
All right, thank you. So to build off what Corbin was discussing with treatment, in psychometrics, one of the most commonly used forms is the Likert scale. It's accessible, it's easy to use, and so for that, it's a very valuable tool for treatment providers to assess levels of anxiety or depression in adolescents. However, a 2017 study found that among a variety of academic fields, there's a overall dissatisfaction with Likert scales. And particularly in cases of anxiety and depression, there are especially high or large disparities between what the patients are reporting and what the professionals are reporting as the care provider. And so from this, there's been a variety of ways people have tried to build off of Likert scales. One way is introducing the analytic hierarchy process, which allows students or adolescents to identify particular regions that they would like to focus on. Maybe that's family health or academic success. And so through this, by being able to identify things in their life that they find important and that they would like to focus on, treatment providers are able to give a more comprehensive care to the adolescents. And an additional study found that a form called the Form of Self-Criticizing, Attacking, and Self-Reassuring scale is also especially conductive to anxiety treatment by similarly allowing patients to identify areas that they would like to focus on or think that they would like to in the future. And so, yeah, with that, Brendan, would you like to open it to discussion, or should I pass it to Amani?
Oh, you're muted, right?
All right. Yeah, let's do the discussion. So we've just heard a few great explanations of these different ways that we can measure psychological phenomenon or sociological phenomena. We'll have the are there any
Were there any questions for the people who had presented so far?
yeah.
Otherwise, I had a question for the group too.
Yeah, take it away.
That's okay. Yeah, so we'd heard an overview of some of the major methods for measuring stress and adversity, and we hope that it's clear that we want this research to be relevant to low-income urban adolescents and youth, as Corbin had touched on. So I was just wondering if anybody was getting into some more novel methodologies in their research and work with communities. One example I can think of that another lab at DePaul works with is social network analysis in Oxford House. So I just wondered if anybody had something they would like to share as far as different methods that they could integrate in their research.
How about the cities project, that saliva sample study we're planning, where we're going to take we're going to look at the hormonal concentrations of different saliva samples of kids in our program, and then see if we can find a way to use those cortisol levels, or this or that concentration in the saliva to validate the measures that we've developed in-house, like the Likert scales. And then ideally, like if we can, get enough of that data to, further validate our scales, we could just go back to using only the scales, but knowing that it is a very robust measure.
Yeah, just interestingly too, one of the reasons why I ended up choosing this article that I reported on about the ventral striatum functional connectivity, just because it is a community-based sample, just like, you know, the city's project, which we're using. These researchers also were able to, you know, go and connect with 57 different public schools within the Brazilian system, you know, and we're again just part of another cohort of a study, you know, really looking at these depression rates in adolescents, and just, you know, going in further and really realizing that there is just such a big need for, you know, expanding any type of knowledge and information on adolescent depression. And, you know, whether that is like looking at etiology or ways to like effectively treat, again, like it is just, it's so common, or just so interesting to even point out that there are just these commonalities, even though they're literally worlds away. So we're in Chicago and they're in Brazil, and they're looking at very similar types of reasons why and how stress is occurring.
Something that actually Corbin mentioned that Zoe you touched on a little bit is working with the school system, that are working to kind of really create these intervention for children that make them feel more safer, maybe more comfortable, being able to open up about maybe if they're having issues, and then able to actually seek out that help right there in their school system. So a study that I actually read was actually placed in the UK, where they would integrate these cognitive behavioral therapy like sessions that actually was built from professionals, so actual clinical psychologists, but in conjunction with actual students as well. So it wasn't just like, you know, government creating some program or what have you, and they actually had like the students right there, you know, creating the, whether it be the propaganda or whether it be like the system or the plan of the day or the structure of it, they had them right there kind of contributing to it, which led to them to believe that it would be more, it had a more positive reaction from other kids, other students. These were mostly Black adolescents, and they also saw that, you know, having it in school, actually, students reported to be felt more safe. Also, on the other hand, other students, depending on the situation, whether it be bullying, they probably didn't feel more safe, but they put it in these environments, which also contribute to the children being more open to intervention and to cognitive behavioral therapies. And they did it with, you know, school-based like library after school programs and things of that nature, and they actually saw a very positive reaction from it. So that alludes to this future possible development for, you know, maybe the government actually takes it a step, because we're looking at multidisciplinary domains. So maybe the government takes a step in and say like, okay, well, how about, you know, for the school system, like we integrate some type of group therapy within it, that people are available, that's available for people, the access is there. You know, kids are already going to school, so it's right there. They don't have to worry about taking the bus or anything like that. So I think it would be extremely helpful and one example to show that we need like multiple domains, just all hands in when it comes to community psychology.
Yeah, thanks, Imani. Do you think, you know, things like group therapy and resources like that should be available in just certain schools, or should that be something that every school should just have on hand, no matter what?
I definitely think it should be available. I think to answer your question directly, I think every school should have access to it. But I think where it may need the most, maybe some schools already have it, maybe schools of private schools or things of that nature, they probably already have that built in. But schools that probably need it the most, personally, where I've seen from the research that I've read, is underrepresented or low socioeconomic groups and environments in schools that probably don't have the amount of resources that others have. I know that Corbin mentioned Chicago, where the CPS schools or Chicago public schools are very under-resourced, understaffed, and whereas you go out to where I live is in the suburbs, and they do have the resources to kind of provide something like group therapy within the actual school schedule or system, whereas in public school or within inner cities, they don't have it.
Right. And I wonder if, just having it in place automatically might just normalize accessing resources like that rather than waiting until a problem becomes too big to handle, and then maybe some students might not even want to participate in a thing like that.
Yeah. All right, shall we move on then? If anyone has any questions, okay. All right, the next section is actually going to be me, where I obviously touching on what we already discussed, we want to really understand like the ideology of how the risk factors actually occur, or where they start and where they form. So a lot of studies I actually read within the last few years really touched on cognitive vulnerabilities. So these being the tendency to see causes of events as stable, so something like unchanging, global, something that is more generalized, and negative, similar to karma, so something that they feel like the child or the adolescent or whoever is experiencing this, it feels like it's either supposed to happen to them, and then self-implicated, which is like it's their fault, and these will be the consequences that they probably will derive from their cognition of the incidents, or what they think of the incidents. And they touched on rumination as well as negative cognitive vulnerabilities, so which they believe form in middle or to early to middle childhood. So we're looking at like before high school age. And these negative cognitive vulnerabilities will cause the child to really take the cognitive vulnerabilities that I mentioned previously, and really, again, with rumination, so repeatedly focusing on the negative mood of it and the negativity of the actual incident. And it was actually shown in one study that girls actually had a higher risk of getting major depressive disorder, simply because they had more exposure to interpersonal conflicts or stressors, which they believe that with the more negative life events that happen, the more repeated negative cognitive thoughts or vulnerabilities or what have you, the child is going to experience, and more rumination, so repeatedly thinking and going over these again negative moods, negative aspects of the situation, and then thus causing a trajectory of them developing either anxiety or major depressive disorder later on in adolescence, or even in adulthood if it's not intervened at some point. Further, actually, to look a little bit more deeper in terms of why would these negative attributions towards these events might be an issue. An article actually looked at how the prefrontal cortex of the adolescents may lead to reward seeking. So, or I should say the underdeveloped prefrontal cortex, and failure to actually seek reward would lead to dysfunction in the reward circuit. So more likelihood again for developing depression. So it's kind of touched on how your stress, like I said before, reward circuit, neural dysfunction, they're all contributions to developing depression. So they looked at these different models, whether it's reward mediation model, transaction model, stress generation model, and they kind of took a new approach, and it's called like a titration model, excuse me, and which meaning it's the degree of vulnerability may be contingent on both the magnitude of the stress as well as the degree of reward, or as well as the degree of reward dysfunction, so dysfunction in the reward circuit. And they actually saw that looking deeper, actually physically, that stress can have a consequence of inhibiting dopamine activity in the reward circuit. So this meaning reducing the release of dopamine and serotonin that the nucleus accumbens actually, that's in the basal forebrain, is actually in charge of actually orchestrating the release of. And then so this inhibitory behavior pretty much what it is basically is the inability for these neurotransmitters, so the chemicals, to actually bind and actually continue to, I guess, word for we transport onto the next neuron. So just that that just line of communication throughout your brain. So essentially it like stopped that communication. And so all this being said is this is just further evidence as to why early intervention or different methods or novel methods could really be helpful in really understanding, and not even understanding, but also just improving the outcomes of adolescent stress or adolescent a risk for developing depression or anxiety, or even later on in adulthood, where you might see even more mental health disparities among these people, among adolescents, because of maybe what happened in their childhood. And we do, like we talked before, see that people that are in lower income neighborhoods and environments do face a higher level of stress due to either stress violence or income. So this could be more of a risk factor. And yeah. And to go to the next person that will talk further on understanding these influences will be Alexander.
Thanks, Monty. So research I wanted to touch on was a study on an expanded version of the ACEs questionnaire, and ACEs stands for Adverse Childhood Experiences. The ACE questionnaire is a 10-item checklist that's commonly administered in pediatricians' offices for well child visits and things like that, just as a way to figure out broadly possibly what a child's exposure to stress and trauma has been. Just to give a quick overview, the original 10 items on this scale are physical abuse, sexual abuse, emotional abuse, physical neglect, emotional neglect, alcohol and drug problems of a family member, mental illness, domestic violence, incarceration, and divorce or separation. And so the researchers wanted to assess the validity of an expanded version of this questionnaire and then see how it correlated with perceived stress using the perceived stress scale and also smoking behavior. And this was a sample of low-income women in Wisconsin. It was a diverse sample of low-income women. And the expanded questionnaire included 7 additional items, which were financial problems, food insecurity, homelessness, parental absence, peer victimization, violent crime victimization, and yeah, that's it. And so they found that all of the additional items and the original items were positively associated with the perceived stress scale, as well as smoking behavior among this sample. And when they did a factor analysis on this, interestingly, they found that the 17-item ACE questionnaire separated into 4 factors, which were interpersonal victimization, emotional neglect and physical neglect, extreme exposure to poverty, and family loss and separation. And I thought this was an interesting study because I think this is something that stress and trauma are typically conceptualized or have been in terms of interpersonal, family-based trauma, things like that. But I liked this study because it looked at more systemic, broader stressors that might also be characterized as trauma, and especially in like a community psych setting probably are understood to be just as impactful on mental and physical health as interpersonal violence and things like that. One of the limitations of the study was that this was retrospective reports, so the average age was about 24 years, and they were basically asking them to recall adverse childhood experiences, and it's not typically administered to young adults like this. And then the other thing, it was all women. But I wondered too if racism and discrimination might be something that could be included in an ACEs questionnaire. And I wondered if that would fit more in the category of interpersonal victimization, or if it should be its own factor. So I wondered if anybody had any thoughts on that.
Actually, interestingly, that makes me think of generational trauma.
Mm.
And then, so I guess it could be both, it can really be something that's felt as a community, but then is just so ingrained that you feel it on a personal level. So that's just, very interesting.
Yeah, for sure.
Anybody else? Anybody else?
No, thank you. And then, so I mentioned before, this is a measure that's typically administered in doctor's offices and things like that. And I wonder if maybe sometime in the near future, these methods that we're talking about that are more biomedical, like measuring salivary cortisol or something, maybe that would be a standard sort of measure that they could do on like a well child visit, where they're just measuring kind of stress hormones, basically, how you would do a blood test just to measure your physical health. And then maybe that would prompt physicians or other professionals to administer an ACEs questionnaire.
So for example, would you mean, say like a social worker, you get a few CPS reports and then you have them come inspect the home using the hormone concentrations? So, I mean, because we're all familiar with the idea of like, if you know that a worker is coming, you're going to clean up everything and be really, and then using the neuroendocrine function, which is, more or less consistent with like how their like actual home life is, and then saying maybe having a better evaluation process, right?
Mm-hmm. Yeah, for sure. Yeah, that's a great idea. And then something else I forgot to mention too was that these researchers made it clear that ACEs or child maltreatment, things like that, is often like a dose response relationship. So, it might be that certain types of trauma are more, harmful to certain individuals, but oftentimes research has found that if you have multiple types, that's usually what predicts more adverse outcomes later in life in terms of anxiety and depression.
All right. So for some reason, I thought that we were going to get done at 6. So Alex, can you post the Zoom link for your personal channel? So, and then we'll go there if we go over time.
Sure. 1 second. Yeah, and that was my piece. So if anybody has questions, that's cool. But if not, like, we'll just move it on to Brandon. He's our last person.
All right. So the final topic before we open it up to the second part of the discussion is multidisciplinary research's role in developing evidence-based policy reform. So, I mean, and that's kind of the end game for us, and why we've talked about all these different kinds of essays and ways of incorporating them. You could there are different ways that this can happen. You could put more strength behind policy proposals, and if you have these if you approach the problem from more and more angles, and they all point to the same intervention or way to revise policy, it's a lot harder for people who are supportive of the current problematic policy to argue against the policy reformists. They could also, since it can be used to educate the general public, we would be acting more cohesively as intervention scientists by providing not just more evidence, but a variety of evidence for people who are more convinced by, like, say, like a specific science. So, like, let's say, someone's like, all right, well, these psych evaluation measures, it's like, how do we know if they're right? Well, so then you supplement with like the neuro stuff that backs the psychology stuff, and then we can reach those voters who are like a little harsher on social scientific interventions. And the final or another way that this can improve the evidence-based policy reform is by educating members of the scientific community that are not familiar with what we do specifically. So essentially acting as community organizers for the scientific community, and then working together in a multidisciplinary fashion to improve our interventions into these marginalized populations. Before I open it up to the discussion, I will give my personal anecdote and what kind of got me hooked on multidisciplinary research. So I, as a psych major, undergrad psych major, I found my way into an anesthesiology research team at Stroger. My whole research team were, med school interns or who had MDs. And at first, I was really, really worried about, it's like, everyone's going to think I'm useless, right? Because I've never been in an OR before. But it turned out that like there were a lot of ways that I could contribute to the anesthesia research team. For example, we were doing a specific study where we were trying to find out ways that we could put people under better based on different risk factors that make it harder. So for example, if your neck is too wide, it's kind of more difficult to intubate properly. And then, so comparing those risk factors to different ways of putting people under, and then figuring out which way or like which is best for these different complications, with the ultimate goal of being having better patient outcomes. Now, I don't really know. I still don't really understand what the different interventions are, but what I did do was take the old survey, which was photocopied a million times, grainy pictures and kind of an inconsistent like rating scales, and then I kind of like redid it to make it kind of like accessible and kind of more intuitive. Making a fancy survey that people will like want to fill out. And I did that. And then, so it kind of really increased like the amount of anesthesiologists filling these out because it was just easier to fill out. Or when preparing interdepartmental briefs, using say like Excel tables and then, formatting it like really, really nice. And doing like APA format tables, and then people just like getting through these briefs better to understand different, like how the degree to which we were meeting infection control procedures. So again, I didn't understand like any of the jargon they were using, but I know like how to make a nice survey because I was a psych major, and I recognized that like making a good APA table that's like kind of flows is makes people more likely to read the table. And those are pretty simple things, I think, from psychology perspective, but it kind of had this, it amplified the anesthesia. And I think that doing this for as many different scientific fields as possible is going to naturally improve the conclusions we draw. And in community psych specifically, it's like incorporating these ideas, cultures, approaches to scientific research is only going to serve to benefit whichever population that we're developing an intervention for. So if anyone would like to throw in ways if they had a research experience where they were kind of like a fish out of water, or ways that you just like different fields of expertise that you brought to the table in a community psych context, and then kind of improved again the ultimate outcome of the data or policy proposal. The floor is open.
I think too the session is about to end, so we're supposed to go back to the main room, but I think if you guys would rather stay or set up another Zoom link to continue the conversation, you'd also be able to do that too.
All right. Alex, you want to set up your Zoom room and we'll all join?
Yeah. I'll leave this open for another 10 minutes, but I hope I see at least my team back there.
Okay.
It's in the chat.
Oh yeah. For the roundtable team, it's not optional.
All right.
Sounds good. Yes. Thank you so much for all your work. It was wonderful to hear.
Thank you.
Yeah. Thanks everybody.
So for the recording of the session, is that going to be sent to us, or because Dr. Grant wanted a copy?
So let's